We have reached the final session. Those of you who have lasted, who have danced, who have eaten, who have drunk wine, it's really wonderful to see you here, and for those who are in our Zoom audience. So we are going to first hear Professor Ann Shildner, who's a good colleague, excellent colleague of mine from the UK, from UCL, and she's going to tell us about clinical trials for hearing loss in the elderly. I think that Ann is here. Ann, are you here? On the other side of the Zoom?
Can you hear me?
We do hear you, yes.
Okay, and can you see my slide?
We don't see you yet, yeah. Can you share? In a moment you're going to see it.
Okay. Well, it sounds as if I missed something, Karen, by not being in Israel yesterday.
Absolutely.
And today, yeah, I can't wait to come back again. Can you see me or my slides or both?
Yes, we can see you both. Thank you.
Wonderful, wonderful. Well, again, thank you for inviting me to join this session. I'm
Sorry, Anne, can you change your presentation? It's in the presenter mode right now.
It is on my screen. What would you like to do? I stopped sharing now, and I can go back to it again. For me, this is presenter mode. Let me have a quick look. Sorry about this. Okay. What can you see now? Can you see my slide in presenter mode? Because I see it in presenter mode.
Yeah, we see it in a presenter mode also.
Okay, so what is the problem?
Just to put a full screen of the slide itself.
Yeah, it's what I see. So I am not entirely sure what you would like me to do, because I am seeing high presenter view now, and
it might be because you have two screens, but we'll manage with the way we're seeing it now. It's not perfect, but we can still see your slides and we can hear you very well. Thanks.
I've switched off another screen, so hopefully this is going to help.
If you put it in presenter mode, it will now. Not yet.
Can you see one or two screens?
No, but let's continue this way, Anne. Go ahead.
Okay, good. Well, apologies. So again, thank you very much for having me. I am an ENT surgeon, and I am running a translational research program in London around hearing loss. And today I would like to talk about hearing loss and dementia, in particular about the implications for research and clinical practice. So why do we, I'm just, because it's so annoying, I just don't know what you're seeing. No, I don't know. Show taskbar, I think that's what I need to do. Right, I can't change it. So why do we talk about hearing loss and dementia in one talk? And I think these two figures highlight how hearing loss and dementia share the same demographic. They're both figures from the Lancet. The left one is about the age specific prevalence of hearing loss, and what we see is that the prevalence really increases very rapidly with increasing age. And this is a graph which reflects dementia prevalence in men and women. And again, we see a very similar picture. So these conditions clearly present at the same age in a similar population. But what has recently become clear is that they don't just coexist, but they're actually associated. And this is a picture that many of you will know from the Lancet Commission on Global Hearing Loss, the Lancet Commission on Dementia. And this picture summarizes a large study, a systematic review of all the cohort studies that have data in it about hearing loss, about risk factors for dementia. And what it was found is that hearing loss acquired in midlife was a major contributor to dementia. And it was calculated that if we could modify hearing loss acquired in midlife, we could potentially reduce the risk of dementia by 8%. And that is really, really big. And of course, when this picture first was published, that was in the initial report, I think it was 2017 or 18, that caused quite a stir, because people hadn't really seen hearing loss in that way. And in particular, a lot of people said, but you find this association, but what does it mean? How are these two associated? And there is still a lot of work to be done about this. I mean, is dementia caused by hearing loss acquired in midlife, or do they just coexist? Is there a common cause for the two, or is it a matter of interaction? And I would recommend to read the paper from Griffiths and many others, How Hearing Loss Can Cause Dementia, which was a really good overview paper. But let us assume that the association between age-related hearing loss and dementia is a causal relationship. And that would mean that if we could modify hearing loss, we could potentially indeed reduce the risk of dementia. And then the big question is, how do we do that? And could we potentially cure hearing loss? And this is the field that Karen and I have been working on together over the past years. It is not going to be the topic of the talk of today, because there are still many unknowns. But the essence is that major discoveries in the mechanisms that underlie hearing loss have allowed for the identification of therapeutic targets and the development of novel therapeutics, completely novel approaches, drugs, genes, and cell therapies that are aimed to protect, repair, or restore hearing. And that means that as a field, we're still quite a bit away from it, are moving, hopefully, to precision medicine for sensorineural hearing loss. As I said, this is a rapidly moving field, but there's still some work to be done. So while we are developing that field, we need to act on what we can do now. And that means that I'll talk about the work that we are doing at UCL, which is about, if we provide hearing care, what does it mean? We ideally would screen or assess memory in hearing aid clinics, in patients that come to our hearing aid clinics, and act upon that. And vice versa, ideally we would assess hearing in dementia clinics and act upon that. And one of those actions could be to provide early hearing care tailored to patient needs, in this case, patients with dementia. And that's a trial, a pilot study that we have just completed, and I'll talk about that today. So when we think about memory assessments in older adults attending hearing aid clinics, what we have recently done is a national survey of audiologists to find out what people think about it. Do they think it's useful? Do they already do it? And if not, what would be the reasons, or what would need to be in place to implement that? And as I said, we did it as a survey across leads of NHS audiology services, and we distributed a Google online survey through our professional organizations for audiologists. It was a quick questionnaire, and so far we have 80 responses out of 260 approach. We're still working on the survey and getting more and more responses in. And about a third of those who responded were leads of audiology services. But what did we find? We asked people to estimate the proportion of older adults seen in hearing aid clinics that have significant memory problems. And what we found is that about half of the respondents felt that maybe, 0 to 1 in 4 patients had significant memory problems. And about a quarter felt that actually up to half of the people they saw in their hearing aid clinics may have memory problems, significant memory problems. So that's quite a substantial proportion. And then we asked them, how useful do you think it is to perform a memory assessment in your hearing aid clinic? And then again, the far majority found that this is either quite or very useful. But then remarkably, if you then ask, how many of those people actually perform a memory assessment in their hearing aid clinic, it turns out that 95% of audiologists say, no, we don't address memory at all. And I recently went through a protocol of what audiologists ask older people who come to a hearing aid clinic, and it's a long list of medical conditions, but remarkably, none of them asks about people's memory. And then we asked about the barriers, and about 70% said, well, we would really need training if we were to ask about memory problems in our clinics. And about 60% said, well, I don't know what to do with the results and who to refer to. And about half of them said, well, we don't have time in these clinics to do anything with memory. And more than 40% said, well, I've never thought about it. And then we said, okay, would you consider introducing memory assessments? And 5% said they would, which is not a lot. And I think that's because we still have those barriers. And that means that we really are going to need to work with commissioners and payers and policymakers to see what we can do to improve the integration of those services. And we are about to start a pilot project where we introduce memory assessments in our hearing aid clinics at our local hospital. And then we are going to look at feasibility primarily. Can we, what proportion of the patients accept these assessments? What proportion completes it successfully? What are the practical implications regarding time that is needed for that clinic appointment? You can imagine that if you come for a hearing aid appointment, that that doing a memory test, in particular with an older person who may have memory problems, that adds time to the clinic, which hasn't been scheduled. So we really need to work on that. And also we're going to look at what level of training of audiologists is required. And then we're going to measure actually what happens with the result of that memory, of that test. And then we will run a qualitative study where we will explore people's views and expectations of doing memory assessments in hearing aid clinics. And I hope to report on this soon. When you want to assess or screen for memory problems, we have a number of screening tests available, and one of those is the Montreal Cognitive Assessment tool. And what we found that if we apply this test, that people with so it's a memory test, it's a memory screening test. What we found is that people who have hearing problems perform worse than normal hearing adults on this particular test. And that is because the test is given by verbal instructions. And if you don't hear them, you don't do the test as well as when you hear better. And therefore, we developed and validated a modified MOCA test that is visually based to address these problems. And we are currently working on trying to reduce the number of items and questions in this particular test to make it more practical to implement in clinics. And so what would be the problem if you have do this test in a hearing impaired person? It may be that the patient scores are lower because the patient can't hear, but actually the cognition is better. And if this happens, you may end up with an over referral to dementia services. On the other hand, if the clinician knows that the patient has a hearing problem, he or she may interpret a low score as, well, the patient probably hasn't heard it, and it means that there may be an under referral to dementia services. So having an adapted test that gives visual instructions how to move through the different stages of the test is really, really important, as opposed to giving verbal instructions. Our group in UCL is doing much more work around auditory cognition, in particular about how do we process sound and speech beyond the ear. Because what has been found that in patients with mild cognitive impairment and dementia, there is a lack of association between the audiogram that we measure and the patient's self-reported hearing loss. So the patients with memory problems, with poorer score on memory tests, they report more hearing problems. So doing a pure tone audiogram may not reflect their actual problems. And that means that going forward, we need to do more work about what are the best tests for auditory cognition in patients, in older people with dementia or mild cognitive impairment, and that's ongoing work. If there were to be a causal relationship between hearing loss acquired in midlife and dementia, then the question is how can we disrupt that path? And that is work that our group of the Institute of Psychiatry, a group of old age psychiatrists, have been working on with us very hard over the past years. And this is a study that ran in a community memory service in Camden and Islington, which is in the north of London. And we started with a very simple study. Do we actually see patients in these community memory services with hearing loss? And can we treat those people with the standard NHS pathway? So without intervening with a particular trial intervention. So what we did is over a period of 3 months, 17 patients that attended these clinics for the first time, and no, not for the first time. They were coming for a follow-up appointment. They were diagnosed with mild cognitive impairment. They had no hearing aid, and they said that they would be willing to get a hearing aid if there were a hearing problem. So what we did is we used so-called Siemens Hear Check. It's a screening hearing test. And out of the 17, only 5 had no hearing loss. The other 12 had hearing loss, and we did a full audiogram in these people, which again shows how prevalent hearing loss is in this population.
Anne, could I just ask you to start wrapping up, please? Thank you.
Yes, I am. So we referred these patients back to the GP, who didn't do anything about the hearing test in 9 patients, and only 3 were actually referred for a hearing aid. So that means that we do need to do an experiment, and this is what is the final bit of this talk, is because we know that if we just provide people in the normal care, then they may not get a hearing aid, or they may get it but not use it. So we designed a pilot trial where we included patients with mild cognitive impairment and hearing loss. They were randomized to a home-based program of hearing assessment, treatment, and support for hearing aid use, or a healthy aging educational intervention and the normal NHS pathway. So this was the intervention group. And then we looked primarily, can we randomize and retain hearing aid use at 6 months follow-up? This trial has just been completed, and I can promise you we see very promising result, and that means high hearing aid uptake in the patients that were randomized to the intervention group, which means, as I said, a package of care that is delivered at home or remote since COVID, which includes hearing aids, but also a package of additional measures. And because of time, I would like to stop with this last slide.
Thank you, Anne, very much for making these correlations and potential treatments and care so prevalent for us.